nuances and some of the madness in my head and why I do things the way I do. Okay, so it's well confirmed at this point that lateral mass fixation is safe. This is an older paper from 2013, but with some of our friends on here, Rick Sasso and Vaccaro and our buddy Jeff Coe up in the Bay Area, and they did a retrospective review looking at a couple studies and then 18 case series, and risk and complication was low. And okay, now we're gonna do this. And fusion rates were high. So nerve injury was 1%. Still, I think that's awfully high. I've been doing this now for many years, over a decade, and I've never had a single cervical nerve root injury. So I think it's just understanding anatomy and trajectory and so forth. And they had no cases of vertebral artery injury out of 758 patients. And then they noted screw or rod pullouts, screw or plate breakage, or screw loosening occurred in less than 1% of inserted screws. And I think there's some nuances to help even mitigate that number. And so we know it's a really powerful technique. This is a trauma case that I reduced all with lateral mass screws. Got this unfortunate paralyzed sole reduced. And then for deformity too, I mean, it's a really powerful tool, and everybody should, leave fellowship with a very solid understanding of this and have this tool in their armamentarium. So when I start thinking about these, actually, I want everybody to put their hand on the back of their neck and go down and feel the most prominent spinous process. Got it? Everybody feel it? Not hearing anybody. Kumar, feel it?
Feels good.
Right. So, it's here and it's a structure at risk. So we're going to go front to back with how I do these surgeries. So I usually do a lazy S around this spinous process just to avoid an incision over, this bony area. And then when you resect the bone above, if you're doing a laminectomy, it even makes that more prominent. So if you've seen some of the post-op patients come into clinic or people that are there for a 6-month or 1-year follow-up, oftentimes they have like this big divot and the skin is very tenuous over that. And that's like a failure point with your closure. So I do these lazy S things, and I don't know where I thought this up. I don't know if somebody had made a crooked incision at one point and I'd seen it and I go, well, that's kind of clever. But you want to avoid this, right? That's nasty. And that's like what comes into clinic on a Friday. So don't ever have clinic on Fridays, because these always come in and it's one of your partners, hopefully not your own. And then you have to take it and clean it up and it's just a mess. So avoid it. So when I do the lazy S skin, and then I will go and separate the muscles in individual planes, and I'll stay in the midline and I'll tag these. So I'll put like 3/0 silk tags on the layers. And that way, when I close, I'm closing each one of those in an individual layer, and you can get better approximation. The temptation is just cut down through, bovie down through, get down there, do the surgery. But I think the opening and the closure are such important parts of this, and knowing the muscles and where they attach with the serratus and the rhomboids, if you're down here, to be able to reapproximate them. And the other thing that I've kind of noticed over the years is the better that you can get these things sewn back down, like, so say you're going down to T2 and you got to get the serratus resected off the bone and the rhomboids, closing them and actually being able to approximate them to a spinous process unilaterally sort of prevent some of this scapular dyskinesia, is if instead of you sewing them just together where they raise one shoulder blade and the other one retracts. So I try to be pretty mindful of that as well. Getting down to the deeper layers, these are oftentimes just elevated sort of as a single clump, but know that they're a lot of individual muscle layers like the semispinalis and the splenius capitis, and then sort of the deeper muscles with the multifidus and the spinalis. Know that they're in there, and when you resect them, like closing these and getting a good approximation at the end also helps to prevent with that sort of deep sunken wound or wounds that split open. Okay, getting down to here, like I hope you all have spine models and you spend a lot of time looking at them and understanding sort of the association of, bone and joint and angles and so forth. Because when you get down here and you start bovying, there's some key things. Number one, don't violate the facet joints until you know your levels. So be pretty cautious, especially if you're like at the C2-3 and you're not going to C2, like don't get into that joint because it's just going to send it on a cascade of degeneration. And then the other thing is avoid kind of bovying over the edge of the lateral mass. And it's kind of like a rabbit hole. It always bleeds over there and you want to chase it with the bovie and you want to go over the edge. But what happens is there's this rich venous plexus and sometimes you're looking right into the opening of a vein and it just pours blue blood at you. So the best thing to do instead of chasing it with the cautery is just to pack it off, keep working, and just, don't get over there with your bovie edge. And again, like always keep in mind just like the anatomy and like know where things are, know where the foramen is and know where the vertebral artery is going to be. And I think half of what we do is like complication avoidance, and knowing where things are or where they should be is the key. So kind of committing, pictures like this to mind, understanding the relationship of the pedicle to the lateral mass, to the transverse foramen, to the body, and understanding sort of that junction of the lateral mass to the lamina is important. So if you're doing your laminectomy, you're not drilling straight down, but you're actually coming in at an angle. So you're going to be perpendicular to, the lamina as you make that cut. So you don't end up getting into the lateral mass and facet joint. So I think we're all angle driven. And the next objective is, once you get this done, is to mark out like where you're going to make your starting point and what trajectories you're going to do. I think no matter what technique you opt to use, and you're always going to delineate the lateral mass in the lamina, and then you're going to make this, crossover here. And your entry point will be dictated by the trajectory you intend to use, and also the individual morphology of that level, because we're usually not operating on sawbones like this, but we're operating on pretty degenerated necks. And keep in mind, like deep to all of this, where your entry point is going to be, the vertebral artery is straight ahead and the nerve sort of drifts down at this angle. And obviously the spinal cord is medial to that. And it's important to know sort of like what that angle or trajectory of this facet joint is, because it can change at every level. Steeper as you get down lower in some patients, and it can be more shallow, but understand this. And I tend not to use fluoro for any of these lateral mass cannulations or screw placements. I kind of just go off of sort of like the patient's own anatomy. And so a number of techniques have been described, and I remember being like a junior resident, how proud I was. I'd go to the OR, I'm going to do Magriel today, or Roy Camille, or Anderson, or on, like, what are we going to do? And you'd remember these angles. That's going to be 25 degrees and this, and it's going to be straight ahead and at 10 degrees. And it was cool to be like, the kid that remembered all the angles, but then I discovered like none of those were really important. The big thing is, with some of these older techniques, the Roy Camille and the Anderson, you're shooting right at the transverse foramen, right? And inherently that's dangerous. Your screw is straight ahead and at 10 degrees, so you're sort of begging to run into the vertebral artery. And taking 5 minutes at each thing and tap and feel, I think is an unnecessary investment in time. And in terms of like pull-out resistance and so forth, going straight ahead or 10 degrees here isn't going to give you anything better than any of the other angles. And then the key is, where do you make your entry point, right? So relative to this cross that you're going to put on the lateral mass, each one of these techniques describes like a slightly different entry point. And I guess I'll also say at this point that if you have a facet, like an inferior articular process that's kind of overhanging the joint, which we oftentimes see, it's good to remove that so you can see the full extent of the lateral mass. So what technique do we really use? And I think most of us have just sort of invented our own Roux technique. Dan Roux actually described this and wrote this, but I think we've all kind of gravitated towards kind of going a little bit median, a little bit caudal to the center of the X and the lateral mass, and then shooting upwards and outwards. So instead of trying to remember angles and trying to approximate that for every level, you just shoot at the upward outward corner, right? So superior lateral corner of the lateral mass. And I think with this, you're going to be safe. And then you get nice, pretty pictures. So let me go with this. So when we're in here, we're going to mark out this transition between the lateral mass and the lamina. And if you kind of ride your bovie down here, you'll see where it changes. Sometimes it's not as obvious, but if you kind of ride that transition, you can mark that out. And I'll mark it out at all levels. And the bovie doesn't leave a great mark. The marking pen doesn't leave a great mark, but you kind of scratch the surface with the bovie and you get your idea, and then you make your X's. And then, okay, so here's the next thing. Again, if there's irregularities of the facet joint, get rid of it with the matchstick, or I have one of these flat biting pituitaries, we call it. I think we call them bitey, or the cervical bone nibbler, the bone nibbler. And then I make my entry points with a 2mm matchstick. And so why this is important, if you take a 3 and you lay it on edge, you're at this angle, you're actually going to make the perforation bigger potentially than 3.5mm, which is your usual screw size. So it can increase screw loosening and pull out. So I start it with the smaller drill bit, and I'll line up all the entry points. So you do have some flexibility as you're going from level to level, to put these such that all these screws will line up, right? And I just pierce the cortex. So I don't take that and I don't push it all the way in at the angle. I just pierce the cortex. And then you come in with your drill and guide, and I'll usually, it's a 2.4mm drill bit. I think it varies by vendor, but they're always sub 3.5. And then I will drill towards the upward and outer corner of the lateral mass. And I'll start at 10 to 12, depending on sort of patient size and so forth, what their anatomy looks like. Usually start at 10 to 12, and then I'll palpate. And with this technique, you also have the ability to go bicortical if you want. And that should be, done quite cautiously, because there are things on the other side of that none of us know how to fix, and we clearly don't want to break. So once I get everything drilled, then I'll tap it. And I like to do this sort of heavy lifting part of the case before I do a decompression, because you're making multiple passes with numerous instruments, and I think the likelihood of tagging the cord increases the more you have in and out. So I like to do all of this up front and beforehand. So you get everything tapped, and that way, once your decompression's done, you can put the screws in without having the tulips interfere with your drilling angle to do your decompression. Okay, so again, if the lateral mass is pretty dysmorphic, you can actually, put an instrument into the facet joint. You can stick a 4-Penfield in, or sometimes I do the bovie, just so that angle. Sometimes everything is just so dysmorphic, you have a hard time telling. But that's a great way of understanding the angle of that facet joint, is by putting something into it. And sometimes we get these levels that are just they're so degenerated that lateral mass is compacted, or it's so dysmorphic, it has a lip here, lip there. And sometimes the juice isn't worth the squeeze with that, and I'll skip a level just so I can get the screws to line up. Or one level is really recessed, and then you got to start thinking when you put in screws, maybe make that one a few millimeters longer, just so your rod lies nicely. And again, here it is. You can stick a number of different things up into the facet joint. Okay, so the next thing I do is I will resect the interspinous ligament between, you know, the upper and lower ends of where I'm going to do my decompression. You end up, you know, taking away some of the spinous process with the Lateral. That's what I usually do. And then I'll perform dome laminotomies of C2 and T1. And a lot of this depends on sort of like the patient's lordosis. If they're like highly lordotic or what have you, you know, those lamina are going to be tighter together, because what you want to do is create a corridor through which you have access to the ligamentum. And so once you do these, you know, dome laminectomies or laminotomies, you know, then you can get in, and I'll loosen up, you know, the ligamentum. I'll come across. Usually you can take it in the midline because it's bifurcated in the midline, and then work laterally and release the ligamentum. So then everybody has a different technique. Some of us use matchstick. Some people use the bone scalpel. Some use the side cutter. I mean, one guy that trained us when we were residents used to use a side cutter, and it was frightening. It's okay for kids, right? Kids have a lot of space. You can kind of zip it up there and their tissues are loose. But I think in the adult population that are really degenerated, it's kind of risky to do. So I think you'll probably have to pick what works best in your hands. I'm a matchstick kind of guy. And I'll tell you, in terms of training residents and fellows, that's probably one of the most precarious things to do, is allow your third-year resident to drill by the cord. And I think, you know, we all need to really focus on, like, you know, that drill technique. And if we don't poke with the drill, we don't push it. I think like our hands are much more, I think, precise and accurate in a pulling motion as you flex your fingers in a palmar direction. And I'll sort of paint these troughs using sort of that pulling technique with the drill, and I'll be really precise with it. So I'll go down through the outer cortex, through the cancellous bone, and I'll thin out the inner cortex. And, you know, like, I've been doing this for a long time, so I'll actually go all the way through that, right down to the ligamentum or dura. But I have confidence in like my drill control. Again, it's always pretty precarious to have, you know, the third-year resident drilling around these areas, because I think, you know, one little slip and you poke the cord and there's CSF pouring out. I mean, it could be pretty disastrous. So, you know, I mean, really hats off to, like, you know, your mentors that are training you and allowing you to do this, because I know inside they're gritting their teeth as you're taking up the drill for the first time doing these cases. So I'll run each level, and I'll usually start down low and work my way up high. So I'll start down at, you know, the C7 level and work my way up, and I'll go up one side, then I'll go up the other, and you always encounter bleeding. You know, I use Hemazorb, the resorbable bone wax. I'll put that on if there's any, you know, bleeding from the lateral mass edge. If you need to put in Surgifoam because there's, you know, epidural bleeding or flow seal or whatever, I'll do that and then go to the other side. And then what I'll do is I'll kind of get like a gut feel of where things are, and then I'll run a Kerrison. I usually use the number 2 up that trough you made. And again, remember, when you drill these, you're going to be drilling them not like perpendicular to the floor, but perpendicular to that laminar edge, right? And so then when I run a Kerrison up, I'll take a bite kind of medial, a bite kind of lateral, a bite kind of medial, so you don't sort of like get your Kerrison wedged into this narrow trough, right? So you bite, and you just work your way up and loosen it. All right, and then what we're going to do is we're going to elevate this bone up and off. And, you know, I'll usually grab the inferior end with a Lexel and gradually start to pull it up. Now, mind you, there's a lot of adhesions underneath this. There's still ligamentous attachments that you might not have released, or there's scar tissues or whatever. So it's not like a big, you just rip it off like you're starting an old rusty lawnmower. You gradually elevate it. And then what I'll do is I'll use the spoon end of a #1 pen field to kind of look under there and make sure that any areas that were adhesed, that I released them. Alternatively, you can use an inverted 15 blade, and that's kind of like a neurosurgery thing. Like when you're elevating like a scalp flap to put a bone flap back in, you'll kind of pull it and use that knife, the belly of the knife, aimed towards the ceiling. And once I get the bone off, I always check MEPs. I'll irrigate. I'm a big irrigation fan, so generally for a posterior case like this, I'll use at least 3 liters. And then at this point, I'll decorticate all the lateral masses, and I'll actually get in the facets and get all the capsule out. Because once the screws are in, the tulips kind of prevent you doing a good decortication, and they kind of can block you from getting into the facet because of the angle you have to take. So I do all that at this point. Now that goes away. Woohoo. Now, when you place screws, again, this is like, there's a little voice in my head that continuously says, don't bang the cord, don't bang the cord, don't bang the cord. And I hear it all throughout, like anytime the cord's open. Doesn't matter if I'm doing a VCR or what have you, anything that's open in the cord area, this like voice just speaks to me. So be really cautious. And this is where like I don't allow anybody to pass me anything over the exposed cord. And I remind everybody, don't pass over the cord, don't pass over the cord. And I'll specifically put my hand down towards a scrub tech so they put things in my hand. And the same thing with your assistant. And no 2 sets of hands working in the wound at once. Things can happen. Set screws can fall off the end of the driver and fall onto the cord. So I just try to be really mindful to, avoid touching the cord whatsoever. So carefully place the screws. And then depending what vendor you use, some of them have like favored angles. So instead of being like, 45, 45, one might be like, one angle might be 65 degrees and the other 30. But know like sort of the capability of the screw and the tulip beforehand and the nuances of them, so you can specifically pick it. Because sometimes at the top of the construct, you want to use one of these favored angles to get you in it. Also, some of them have kind of like, heads that will favor medially. So if, you do have some sort of sweep, like say a T1 or something, you can use these. So you end up with sort of a flowing rod versus having to use offset connectors or things that look kind of quirky and have just like another failure point. Okay, so get your rod contour fine. And just remember that, if you have screws that are at different levels, so, getting that little arrow thing you put in there, that little mini reducer, sometimes it's not really reducing anything. It's just going to pull your screw out. And so then if you do that and you pull a screw out, so avoid trying to reduce, screws to the rod. Try to get your screw heads to line up such that the rod just sits in. And if you are trying to do a reduction, it's a whole different train of thought of what you're doing. And then get your set screws in, and then final tighten. And again, just be cautious passing things over the cord. And then bone grafting, whatever it is you're going to use, like morselized autograft, allograft, just make sure that you get stuff into the facet joints. Like I particularly like to actually, drill out those facet joints and get graft up in there. There are commercial products available where you can, drill into the facet and then put a little plug of DBM in there or some other things. So, the goal of this is to get things to fuse. So be really mindful of your graft and where you're putting it. I'll place Fibrillar over the Dura just because not like the full thickness, you get it and it comes in and it's like, 1/8 of an inch thick. I'll peel off like maybe 2 layers of it and I'll lay it over the Dura just so you have a barrier. So if you do ever need to come back and as you're resecting, there's a plane between the Dura and the muscles. I'm a fan of big channel drains. So I usually put a 19 round Blake in the deep area, and I'll try to put it in such a way that it's not lying on the cord, and I'll tunnel it out somewhere at the lower lateral pole of the incision. And then the other key is when you're removing the retractors, be sure bone graft doesn't like fall down in there, because you're using like the hook retractors or whatever, and is when you pull those out, things like to fall in on the cord. So check that out. All right, changing gears to laminoplasty. Our friends over in Japan originally described this as a non-fusion alternative to decompress multiple levels of the cord while avoiding, post-laminectomy kyphosis. And it was also devised for other things, like to kind of avoid problems with segmental instability, kyphosis. And one of the big things, if you actually go back and read the papers, one of the things is that post-laminectomy adhesions, right? Because there were some papers that they looked at, and sometimes you get these adhesions which can cause restenosis and then end up with late neurologic deterioration. So that was one of the big things that, the notion leaving the bone over this would prevent that. So the first laminoplasty technique was the modification of Kurita's technique for laminectomy, in which lamina were thinned and thinned and thinned and then partially removed. Then Oyama developed this Z-plasty method of laminoplasty. And I can just imagine like how unfun that would be to do that procedure. A bunch of years ago, one of our fellows, Eddie Nemoto, which some of you may know, went to Japan and spent some time. And I remember like the thing that he was most impressed by was how much time they spent doing individual procedures. Like they would spend like an entire day doing stuff. And I can only imagine how challenging it is to thin everything out and then do the Z-plasty. No thanks. So Kurokawa developed this sort of French door where you make your troughs, then you open up the midline, and then you push these open. You can put some bone graft there and suture that in. And it's also a very, very technical case. And I personally have done one of these. I had a mentor, Ken Yanamura, Japanese guy, and he loved to do like these really esoteric surgical procedures. I don't know, just for the sake of doing it. So I did one of those once and I didn't really care for it. Hirabayashi reported this open door laminoplasty, and I think this is probably what most of us use. Have been attending these conferences for ages. I think when I see like what Bob and Greg do, this is kind of what we do. So the notion of this is, you make like a green stick fracture on one side, a complete opening on the other, and then you elevate this up and off. It's still a very technical procedure, and you have to be pretty precise about what you do, and also avoid getting to the lamina or the facet joint. So that's the big thing. The difference between, doing a fusion and doing a laminoplasty is you don't want to get your bovie in there. So there's a lot more care and precision that goes into the approach of these as you come up and over that lateral mass laminar junction, stay out of the facet. And it's the same thing, you delineate the junction between the two. And then depending what vendor system you use, I happen to use the one that has a purple stick on it. And you start out by using this little guide, and you'll put like a small screw into the lamina, but it'll tell you kind of like where to put it based on what size opening you want to do. And there's a tiny little drill. So you put this little 1.5 millimeter drill bit, and then you put the laminar screw, and you do it at all the levels. And then you drill sort of these partial thickness on one side, and then you do a full thickness burring on the other side, and then use a kerosene to complete this. And then, you use a little gentle traction to rotate the lamina over. Now, I've kind of gotten to the habit of leaving the inner spinous ligament intact between like C2 and 3 and C7 and T1. I don't know why, but I do, and it gives me sort of like what I need for elevation of these things. And then like once you get it open, check your motors, because now you have sort of this flapping like roof of bone. And so with the system I use, they have like these little pickle fork kind of things. You kind of put it up and under the screw, and it has this little lip here that holds the lamina. And then it has this little flange that hangs out here. And so you kind of hook that on the lateral mass, and then you determine, okay, you got to zip, put in a screw, put in another screw to stabilize this open. And you do have kind of the option of putting a piece of bone graft in there. A number of vendors sell sort of a bone graft. And so similar, as I was saying with the other one, you know, one of the big things is this approach angle. You're not going straight down because you're going to get into the joint and the lateral mass, but you work at this angle, which is perpendicular to the lamina, complete on one side, partial on the other. And it's nice to do the open side first, like you get down, and then as you're drilling the other side, you can kind of put your thumb on the spinous process and pull it up at each level. And then, you know, it gets to that wiggle point, like a loose tooth. It's like pop, and you're like, okay, it's good. Pop, it's good. So as you work your way up, you're able to, you know, do that spring test to make sure that it's loose and open. So it's such an awesome procedure. You know, you just got to pick out the right patient for it. And then, you know, here's like one of these other devices that actually has a chunk of bone graft. I think these were the ones I used in fellowship, and I migrated away from using those and just use a plate. And then here's sort of like CTs afterwards of, you know, what these can look like. Here, you know, they opened it, but they probably could have got it opened a little bit more. So you can pick the plate, the size plate, and how much opening that you'd like. And then one key thing is like in determining like who's a candidate for laminoplasty. So when these kind of first made their way to the US territory, it was always a person who was straight to lordotic, who didn't have axial neck pain, and had multiple levels. And since then, you know, I think that's changed a little bit. I think we're a little bit more thoughtful of patients with a high T1 slope, because that can affect your kyphotic alignment after laminoplasty, because this can happen, right? Because when you think about it, when you kind of take all the muscle off, in a sense, you denervate it. And if people have a high T1 slope, they can potentially end up with a kyphotic deformity. So I think it's patient selection. And, you know, we talk about K-line at our conferences, and will the cord float away? So, you know, just choosing the right patient. I've heard some people say like, laminoplasty is a great surgery without a patient for it, but I don't think that's true. I probably do maybe a handful, 4 or 5, sometimes 6 laminoplasties a year. I think they're really savvy surgeries. And sometimes you've heard sort of the discussions back and forth between your mentors in the conferences. Sometimes like, you know, you might be like, yeah, well, I can do like a multi-level ACDF and then maybe a laminoplasty in the back, you know, ACDFs to get sort of angular correction and then what have you. So it's a great tool. I want to spend a few minutes on wound closure. Like, I hate infections, and I kind of pride myself that I really haven't had a deep infection in a number of years. But a lot of it comes down to the windup when you're making an incision and the closure. So these posterior cervical wounds just like have a propensity to break down for a number of reasons. Number one, there's a high tension load on the back of the neck, right? Wounds pull apart by muscle tension and use of the arms. You get the diastasis of the deeper muscles, and then it starts sort of that cascade of things pulling apart. Patients also get dependent edema, so they're lying in bed and, you know, they get edema in their wound and so forth, and it helps to encourage the wound edges to pull apart. And then you can get pressure ischemia from orthosis and also neck habitus, right? So these necks can be difficult to close, and I have a special technique I'm going to share just with you today for a small price of $19.99. But these necks can be difficult to close, but we do have to encounter them. So there are some tactics you can use to keep it going. Again, like when I do my closures, I'll take the deep muscles. Okay, I'll put a 19-round Blake in, close the deep muscles over it. And what I'll do is I'll use a really wide needle to grab the muscle bellies and pull the muscle bellies together. And if I feel like it's a person with kind of like a kooky body habitus, like really rounded shoulders, sometimes I'll actually use like Ethibond to pull those muscles together. I don't rely just on like the muscle fascia, the more superficial fascia to hold them together. So I really try to get them really closely approximated so you don't end up with that diastasis. And then I close the muscular fascia separately. And then usually once I get that layer closed, I'll irrigate everything out again. And if it's a particularly kind of juicy wound, sometimes what I'll do is I'll put in like a smaller 15 round Blake in this level. And so then like you get some of these other more superficial layers together. I'll do a separate layer on that. And this is also important. Like say you have a person that does come in with an infection, you have to go in and clean it out, or their wound kind of pulled apart. Going in at that point and, you know, separating these layers, and then you have multiple layers of closure, which helps to detension the skin edges, right? So being mindful on the approach helps you be more specific on the closure. And then, like I mentioned, the same thing with like the serratus and the rhomboids. If you can pull those muscles and unilaterally reattach those to the spinous process that's still in place, because usually you're not taking like T1 and T2 off, but if you can pull those over and tie that bundle to it individually, you know, it's a great barrier for things pulling apart. And those are high use muscles too, you know, shoulder blade retraction, and so forth. So those muscles have a tendency to want to pull apart. And then I perform a multi-layer closure almost to the point like it's probably annoying to close cases with me, because I'll do, you know, 2 O's or 3 O's, and I'll do a plastics closure where I run like a monocryl, and then I'll use Prolene, 3O Prolene, to do horizontal mattress sutures, because what it does is it grabs here and here and it pulls the incision together. So like what you want to happen is epithelialization across, you know, your incision. And this helps just to take tension off it so it heals, because there's nothing worse than patients come back and they have all that fibrinous exudate and something pulled open, and then you take a cotton swab and you start poking around and you realize there's this big tracking thing. So I use this closure on all my posterior cases, and it takes a little bit of extra time to do, but it's time well spent. And wait, let me see some. Okay, we'll save that one. And then what I do is when they come into clinic, I will take them out gradually over time. So I'll look and see where things have epithelialized over, take that one out. And sometimes they come back, you know, a couple times. You know, there's been some people with kind of like crummy skin, or, you know, just poor like nutrition. And some of the sutures might be in for a total of 6 weeks. And I have, you know, my staff just trained up to recognize which ones to take out and so forth. But, you know, knock on wood, I haven't had to revise any posterior cervical incisions in quite a while. I had to revise one of the other guys like last year, and it was a disaster. He had a hole in the back of his neck the size of like, you know, a navel orange. It was crazy. And it was like an amazing plastics closure, like going and fishing out all the layers, pulling them together. And I saw him last week in clinic, and I think he's 6 months out now and he looks great. But I think being mindful of these techniques just help prevent like untoward things down the road. So this is what I call the water ski technique, because we do get these people with these pretty thick necks with these deep creases. So if you look over here, what I'll do is I'll take really heavy suture, like a 1 or something like that. And what I'll do is I'll put them like on either side of these rolls, and I'll put them really wide here. And what I'll do is I'll water ski on it. So then I'll pull down on like, so if you look at this upper crease, right? So I'll pull down on these. And so that way, while you're sewing, putting in your monocryl or your prolenes, you can get in there, right? You're not missing out on something deep in here, which is a key point where it could break down. And then like the other thing is you can have pull up on those and pull down on these to get at that crease. And then just lay back, bro. Just ride that water ski the whole way. And so I've gotten pretty particular about like my dressings as well. And I think of this as being equally as important as any other part of the case. So after, you get everything closed, you get all your stuff on, what I'll do is I'll DuraPrep the whole area, because you can get DuraPrep into the incision, unlike ChloraPrep, which you technically shouldn't. So I'll kind of re-sterilize the other thing. And then the DuraPrep's also a little bit sticky. I let it dry, and then I'll put fluffs over this, over the incision, and then I'll put an Ioban on. And I'll leave it on for 2 weeks. I don't take it off. Peter Newton does the same thing with his peds. He leaves it on for 3 weeks. People are lying on there, they're rolling around. And, I found it particularly helpful with my, big deformity cases. I went to that proneo phase for a while. I put that on. I'm like, oh, it's going to be great. And then they roll around in bed. They're, not having great, perineal hygiene, and there's, fecal matter in the bed or whatever, and it just grates into that wound. So leaving this dressing on for a couple of weeks, it keeps it clean, keeps it sterile. One other little anecdotal thing is one time I sent this guy out he went to a rehab, and he went someplace over by like the Arizona border, and he was there for like 12 weeks, never came back. He came back for his 12-week post-op visit, and he still had his original dressing on that he left the hospital with. And it was one of those things, you open it, you're like, oh, this is going to be the worst thing in the world when I get this thing opened. And I opened it up, and his wound looked great. And they're like, maybe there's something to leaving these dressings on, provided nothing's festering beneath. So again, I'll leave this on for 2 weeks. I'll take it off in clinic. And then what I'll do is they go through like a daily wound care thing. So they take a shower, let it air dry, have their care partner wipe the incision down with betadine, and then they put like an Island or Metapore dressing on it. And then they come back every couple of weeks, and we get the rest of the sutures out. And that's the same thing for the big deformities. Okay, clavicle supports. Sometimes you get those patients with those rounded shoulders, or sort of that, big buffalo hump, and you just know that they're going to pull their wound apart. I'll put them in one of these torture devices, just because it helps to keep tension off the wound edge. And again, like this one guy that I revised his wound 6 months ago that one of the other guys had operated on, he was this enormous guy, and, big shoulders, rounded shoulders, and he pulled his thing apart. And so then afterwards I put him in this thing, and he hated it. But, I closed like this navel orange size, like defect in his neck, and it closed up beautifully. So keep this thing in mind as well, as like just slapping that on people. And that's kind of what I got to say. And now we're open for questions from all of our trainees. Who's there? Anybody? Bueller?
We're there. That was awesome. Thanks, Don.
Yeah, thanks, Don. Lots of valuable tips in there. Really appreciate it.
Yeah, there's so many little nuances, and sometimes it's tough to stuff all that into a fellowship year. And sometimes your mentors are doing things, and they maybe don't vocalize what they're doing, but there's a reason why they do it. Like having, operated with Greg for a bunch of years, like I would study him. I'd study like, well, why is he doing this? And why is he doing that? So there's a lot of these little details, and don't be afraid to ask during surgery, like, hey, what's that about? Why are you doing this or that? Because when you get out there on your own, some of the things that you worry about are like this or that, but like some of the little nuances that, like I discussed today are really important, and it'll save you the headache of, getting bleeding or burn into the dura or wounds peeling apart, because they're no fun.
Hey, Don, anybody, this is Dave Glassman. Anybody doing a L3 laminectomy with laminoplasty, inferior to that for increased range of motion? I've seen some people talk about that.
Like I've done probably young people with tumor. I've done like lumbar or thoracic laminoplasty.
I meant C3, forgive me, C3.
Oh, C3?
Yeah.
to do a laminoplasty for increased range of motion?
Well, it's C3 laminectomy and then a laminoplasty from 2 to 7.
I haven't personally done it, but I think people have, you know.
I don't know if anybody else has
One of
an
my
opinion on that.
Mike Kelly swears by it. He thinks when you open up the C3 that it causes a bunch of pain with neck extension. So he always does a C3 lami and then only does the laminoplasty below that.
Yeah, it kind of makes sense. You just think where bones hit, right? Yeah, it makes sense.
But
I
none of
don't
y'all
have
do
like
that.
an N of 500 to say like I notice a difference one way or the other, unfortunately.
Well, thanks for the talk. Really appreciate the time.